afternoon, everyone. My name is Rachel Pugliano. I'm a senior manager here at Eide Bailey, and my background is mainly in coding and coding compliance. Prior to taking on a consulting role, I worked for an academic medical center as well as a health system, both in compliance functions. I moved over into consulting about 10 years ago and have been with Eide Bailey since January 2018. And Susan, I'll let you introduce yourself.
Thanks, Rachel. Hi, this is Susan Rohde. I am a physician healthcare manager at Eide Bailey. I oversee the physician coding department. I've been at Eide Bailey almost 20 years. We're coming up on the 20-year mark. And prior to that, I was at a large PPS hospital in North Dakota. My role mainly is coding reviews, coding support, and then overseeing the physician coding staff at Eide Bailey. All right, can we have the next slide, please?
Yeah.
There we go. In today's presentation, we're going to accomplish the following things, and we are going to get in detail of each one of these. We're going to outline the steps that your facility needs to help you set up your coding and billing audits, your internal ones. We're going to discuss how to determine the focus areas, what you should really zone in on. We're going to determine how you should prioritize your findings once you're done with your audit or your review. And then we're going to discuss any follow-up strategies, what you can do to put what you find into effect. So what exactly is an internal audit plan, or as you will see it throughout this presentation as an IAP? It's essentially understanding why internal coding and billing audits are necessary for your particular facility. You know, you want to get a plan in place to provide a review of your organization's processes and procedures. You want to ensure financial and operational controls are in place. And these controls are, you know, basically what your mitigating risk factors are. And to go over these just a little more, I'm going to hand it back over to Rachel.
Oh, it looks like we have a polling question, or I can speak to this slide a little bit more too, actually. So Susan already touched on this a bit, and about what the internal audit plan is and why we do that. It's really designed to give the organization a formal outline or roadmap of what the processes and procedures they plan to review for a given time frame. Usually we see that these are structured for a 12-month period of time. Usually it falls within the organization's fiscal year. And these reviews just ensure that financial and operational controls are in place. Coding and billing functions typically fall under that operational control. And we'd like to see these as part of the internal audit plan, as these areas are very highly regulated. Coding and billing rules change constantly, and lack of following these rules can pose risk to the organization, as well as have financial risk associated with them as well. So we have a polling question.
All right, our first polling question here. Does your organization have a formal internal audit plan in place?
Oh, okay. So about half, almost half of you have an internal audit plan in place. Some of you aren't sure. And then we've got about, look like 36% did not. So where do we start with the internal audit plan? What should be one of the first things that you do? What we suggest is that you may want to conduct a risk assessment. And what that is you identify individuals within the organization from a variety of areas and departments. The individuals can be from senior leadership roles, but they might also be more in supervisory roles or even frontline staff. We like to see people included from all different backgrounds and that perform a variety of functions within the organization. That way you get a sampling of different types of risks from a variety of perspectives, not just maybe from a business office perspective or from a nursing perspective, but from all functions within the organization. After you identify the individuals for the interview process, then we conduct the interviews, and they're brief interviews. They don't need to last a really long time, maybe 30 to 45 minutes at the most. And we ask the individuals to share where they feel the organization is at risk. And sometimes that individual might share something very specific that you know is something that they've probably worked with on a day-to-day basis. Other times it might be something that they've heard in the news, or something that they've just heard, maybe some rumors about in the organization that they don't know a lot about, but they have concerns about it. So they bring that up during the interview process. So after they share the areas that they feel are risk to the organizations, then we ask a series of questions that help identify what level of risk is this, how likely is it to occur at the organization, what are the mitigating factors that the organization has already tried to address that risk, and then what the impact is to the organization as a whole, even after those mitigating factors are in place. So once all of those all the feedback from the interviews is collected, we then can start going through and prioritizing those results. And we can find areas many times where maybe multiple people brought up the same risk concern. And when we see that, we definitely want to pay attention to that and put some focus in those areas. So we'll see that these interviews then point to areas that might be billing and coding related, or where billing and coding may be involved or touch that process at some point. And so that might point us to conducting a revenue cycle assessment, or maybe it's a charge master review if it's something that maybe a concern was that we're missing charges in a certain area. We might even look at the clinical documentation or perform a review around the electronic medical record. Maybe there's some gaps within the system where we're not capturing documentation or capturing charges, and so something around that functionality might be warranted. So this is, we hear a great deal in newsletters and various email alerts about specific judgments in cases where there's been fraud or documentation issues and overbilling of the government and those sorts of things. So this slide just kind of points to things that we've probably been hearing about recently. And we know the opioid epidemic is something that's been under a lot of scrutiny and a big focus for the government right now. And while this might not be something that happens in your organization, it could point to us maybe taking a look at, well, what are our prescribing practices for our providers in our pain clinics, or if you have that kind of a department. So it might just point you in areas that you want to touch base on. And some of these are really, really big things, like a provider seeing patients in a location where they weren't even allowed to be located there any longer. And that brought to light some copy and paste issues, which we know we talk about that quite a bit in our organizations. A couple of these other ones, falsifying documentation. I know as coders, we're looking at documentation all the time to make sure that it's accurate and complete. And in this particular case, the surgeon was making some false statements about the complexity of the procedures that he or she was performing. Lastly, there's a money laundering scheme that involved medical bills. And all of this is to say that even though we might not see these particular types of situations in our day-to-day in our organizations, at least we hope not, we know that government agencies are on the lookout because of these bad apples that are out there. So we want to make sure that our practices are compliant with CMS guidelines, and we want to make sure that if we're ever asked to submit medical records for a record review, that our documentation and our work meets the standard. So this diagram just illustrates how the internal audit strategy branches out into so many different functions within the organization, and such as monitoring. We want to make sure that we are continually monitoring. An audit and a formalized audit around that is one thing, but then ongoing monitoring is another piece to that. So are we doing that consistently in our organization? The risk assessment, which we just talked about. When was the last time that was performed at your organization? When was the last time you asked those questions to some of the employees? And then the reporting. We might be doing maybe some informal auditing or some of that monitoring, or taking a look at some claims now and then, but are we keeping a record of that work that we're performing so that we can show that we do have some processes in place and we are looking at areas within our organization and ensuring that we're doing things correctly. Okay, so I'm going to turn it back over to Susan.
All right, thank you, Rachel. So there is a hefty amount of information out there, and we've just heard quite a bit of it, but we like to maintain that there are 4 basic steps in this process. All right, there we go. Step number 1, we're going to establish our auditor. So who's going to perform this? Is it going to be somebody from within your facility? Are you going to have to reach outside your facility? And again, we're going to go over each one of these in depth, so don't worry about that. Number 2, the frequency of the reviews. How often are you going to perform these? Quarterly, monthly, annually? We're going to establish an accuracy goal. What's the minimum accuracy that your facility will accept? And then once you get that accuracy goal, what happens if you don't meet it? Are there steps in place for educational purposes, etc.? And then we're going to establish an audit size or a selection process. How many charts and which types of charts are we going to review? So let's start with the first one. We'll start at the top. We're going to establish an auditor. Who's going to perform these reviews? We definitely recommend utilizing credentialed staff. We understand that's not always a possibility, but if you are able to, we prefer either a HEMA credential or an AAPC credential, depending on what you have access to. The first 2 you'll notice, the CCS and the CCSP, those are HEMA credentials, or the American Health Information Management Association. And the third one, the CPC, the Certified Professional Coder, is an AAPC credential. Neither is better than the other. We just would prefer you to have a credentialed staff. If you're going to go outside of your facility and hire an independent consultant, we recommend very highly that you verify that that consultant is credentialed and they say they are who they say they are. Or are you going to have a blend of both? Are you going to have someone from within your facility working with an independent consultant? And then you can also engage an audit partner. Along our travels, we have definitely also seen where an LPN or an RN will step in, especially if they're part of your compliance department and they're already working on CDI issues. We've seen several facilities where the compliance department is made up only of LPNs and RNs, and they may go back and get a coding credential, but they're qualified to look into, like I said, those CDI issues. Oh, we have another polling question, it looks like.
Okay, our next polling question. Are all of the coders within the organization credentialed?
Oh, that's excellent. Almost half of you have coders that are credentialed within your organization. The other half, maybe you have a process in place to get your staff credentialed. We do see that quite often, that there's an incentive for your staff. Maybe you pay for the test. They study on their own time, but you'll pay for them to take their test. That's always a good one because, like I said, in the end, we do like to see credentialed coders performing these reviews. The frequency of the reviews. So basically, how often should you be doing these reviews? That's definitely dependent on your facility size. It's different if you're a very, very large PPS hospital or you're a very, very small rural health hospital. But in the grand scheme of things, we like to recommend quarterly. Now, how you go about choosing your quarters is up to you. You may have a different year end than other places, so you want to do it your quarters differently. But typically what we see is the January to March, the April to June. And then if we see any significant issues that are identified during these reviews, we may want to do them more frequent. We like to call these quote unquote trends. So if we're seeing any trends such as maybe you never have any start or stop times on your infusions, or maybe these reviews identify that every time you're assigning a drug, you're only using a unit of 1. You're not going by what the HCPCS code says. If it's 20 milligrams and you're giving 80 milligrams, you're not doing 4 units. You're consistently getting the units wrong. Those would be some significant issues, and we would recommend doing the reviews more often until those are remedied. All right, and with that, I'm going to turn it over to Rachel so she can talk about your accuracy goals.
Okay, so there's no black and white statement that's been issued by any government regulator necessarily that tells us we have to maintain this accuracy rate across the board for every type of audit that we're performing. However, in the past, we have seen the OIG state that their standard is 95% accuracy. And we've seen them apply that to organizations that might be under a corporate integrity agreement. And I worked with an organization where we were under one of those, and that was the standard that we were held by for every quarterly audit that we submitted to the OIG. So we feel that best practice is to, moving forward, to maintain that 95% accuracy rate. And then that helps determine the threshold for all of your audits. So once you receive those audit findings from the various projects that you're performing, then that will help you determine where do your priorities lie? Where are our greatest risk areas? Where are there greatest opportunities or weaknesses? And where should we focus most of our efforts? And then once those audits are completed, then it makes it a little bit easier to prioritize based on that accuracy goal. If we have an area that's only meeting an 80% accuracy and another area that's more at like a 92 or a 93, we're probably going to want to put that area that's at that lower accuracy rate higher up on our priority list. So this is just a very simple graph that we oftentimes use to identify the severity of the risk and help us prioritize the action. So something that might be a very low accuracy rate, say we're only meeting 75% accuracy, and we're finding that every single claim that we're reviewing has an issue with it, well, that might be a severe risk and something we want to address immediately. And that might even turn into a pre-bill situation where maybe we perform the education and training for that area, and then we do a pre-bill audit so that we can ensure that all of the documentation is correct, all of the coding and billing is correct before we actually send that to the payer. And then you can see through this chart that it kind of goes down from there. So a high risk, maybe you have a better accuracy rate, but it's still something you need to address immediately. Medium, maybe it's maybe there's a high number of errors, but the financial impact is really low. Those are kind of two different things to review. Even though we want the accuracy rate to be high, if it's not impacting an actual billing error or a billing piece, maybe that's a little bit further down on our prioritization when it comes to comparing to some of the other risks that we see. And then the low and insignificant would be maybe some errors that we see where the documentation could be a little bit clearer, the documentation could be better, but we do have the support that we need in order to support the billing, and it's just a matter of helping that provider beef up their documentation a little bit. So then when we talk about establishing the audit size, that's key in determining accuracy. For example, actually we have a polling question, so I'm going to go ahead and we'll do that first.
Okay. Typically, how many records per provider are recommended for a professional coding review?
Okay, so we kind of have a smattering of answers on this one. So the actual answer is 10, and this is pertaining specifically to a professional coding review. So what the typical standard is 10 records per provider in the professional coding example that we're using here. But we'll talk a little bit more about sample sizes in the next slide. So as I said, this is a key for determining accuracy. One thing we don't want to do is have too small of a sample size, because then we're not really able to identify trends. And also it might skew our accuracy rate. For example, if we only look at 5 records in the emergency department, for example, and we find that there is an element of error in an area on each one of those, it's going to show that there's a 100% error rate in the emergency department billing and coding area. Well, that's probably not necessarily true. So because of the volume and the different types of cases that come through the emergency department, you definitely would want to look at more than 5 records. When it comes to professional reviews, that 10 records per provider is the minimum that we would ever want to review, and the reason being is, again, because we want to make sure that we are identifying trends in the documentation and the code assignment for those providers. And 10 does not have to be what you necessarily review. Sometimes we review 25 per provider. A lot of times it depends on the volume that that provider sees and also the manpower. We know that there is a limited number of hours in the day. There's limited individuals that can perform these types of audits. And so sometimes in order to complete our audit plan or to cover as many providers as possible, 10 seems to be what we're able to do, and we can satisfy that minimum requirement that we would like to see. For hospital inpatient outpatient services, now that's a little bit of a different animal because each department has different volumes. They're structured differently. The emergency department is very different from radiology, and radiology is very different from surgical services. And so we might have to structure our sample size based on data that we pull based on volumes, codes that are utilized. For an inpatient, it might be DRGs assigned, and looking at it from that perspective. Again, facility size is the key as well. So larger facilities, you're probably going to need to focus your audit to a specific department. So instead of looking at all outpatient claims, we would look at emergency department. And depending on the volume in your emergency department, you might even narrow that down even further to specific levels that were billed out of that emergency department. Or maybe you only want to view patients that came into observation through the emergency department. There's a lot of different ways that you can review records based on the data that you pull. Might want to focus on a high volume surgical area, for example. Maybe it's interventional radiology, or maybe it's a certain type of scope procedure. Oftentimes we like to review new services. So if there's a new service that's being performed at the organization, maybe the focus of the audit is simply just on that one new service line. It's always a good idea to review new providers. A lot of times we see that when providers are onboarding, they're given a quick coding and billing presentation from someone in compliance. And they talk about the importance of documentation and the key components. And if the provider is responsible for choosing their own levels, they'll talk through the process for that. And then the new provider is then reviewed by coding compliance within the first 90 days of them onboarding, and given some feedback during that time on their documentation and how they might be able to improve. And so that really helps then get that provider up and running in the way the organization would like them to be. And also new coding and billing staff is another area. Sometimes we need to perform reviews for our own departments. And when a new coder or a new biller is starting out, it's a good idea to touch base and take a look at their coding practices, take a sampling of their records within that first 30 to 90 days, and provide feedback to them as well. Okay, I think I turn it back over to Susan now.
Thank you, Rachel. All right, now you have heard all of this great information and you're thinking, I definitely want to do this. I'm going to start this with my facility. But then your next thought is, I really have no idea what charts to pull. I don't know what issues we're having. I could talk to the business office or the coding department and check, but really I'm at a loss. Well, now we're going to get into how we can help with that selection process. But first, polling question.
All right, our last polling question here. How does the OIG communicate its work plan?
Okay, it is definitely understandable that over 50% of you put annually. The OIG just recently changed how they perform their work plan. So the OIG was annually. They would come out with their work plan. You would wait by your desk with bated breath, and then you would go on and you would devour that work plan to see what they were looking at. But now they decided that they were going to make it easier on you, and they now on their website, they update it monthly, and they put new quote unquote issues out there that they're looking at monthly. And how this is really helped, because now they can look at more trends, we can see more issues, and it really is much more user friendly. Like I said, when it was annually, you really had no idea what day they were going to come out with this thing. You had no idea how many issues. They could look at one issue, they could look at 10 issues. You just really didn't know. Now they're pretty transparent on their website. What I recommend you do is set a calendar reminder, or if you're old school like me and you have a planner, write it in your planner at the beginning of the month, check the OIG website. So you will go on there, and if you don't know how to get to it, the simplest way is in Google, type in OIG work plan. It's the first thing that pops up. Click on that. You'll find all the new additions under the recently added tab. So you'll click on that, and then you'll be able to see everything that they're looking at for that month. The next few slides I'm going to show you are basically screenshots from that. Also, you're going to be able to see the OIG's self-disclosure protocol. So if that's of interest to you, I did link the website here, but it's also on that OIG work plan. All right, so these are current OIG work items. We have that opioid misuse, and underneath it, you'll see it says completed. So when you're on the OIG website, it will tell you if they're active or completed. And if they're on there stating completed, that means they were recently completed. They don't keep them on there very long. So that means they were completed within the last 3 months. We have the end-stage renal disease visits by physicians. That's active since April of 2019. We have that severe malnutrition, which I think is on the OIG work plan permanently, but they do state on there that it's partially completed. We have that podiatry and ancillary services that's been active since February of 2019, and then duplicate payments for home health services, and that's been active since January of 2019. This is just a smattering of ones that I picked across the board, so you could see a little bit of physician, a little bit of hospital, a little bit inpatient, a little bit outpatient. This next slide here is exactly a copy and paste. I copy and pasted it right from the OIG work plan site. So I happen to pick severe malnutrition. There's a hyperlink. You click on it, and then this is exactly what comes up. So the OIG is telling you verbatim what they're looking for. First, they're going to tell you a little bit about malnutrition, how it should be treated. And then at the bottom it says, this review will assess the accuracy of Medicare payments for the treatment of severe malnutrition. We'll determine whether providers are complying with the Medicare billing requirements when assigning the diagnosis codes for the treatment of severe types of malnutrition on inpatient hospital claims. So basically, we know malnutrition has been on the OIG yearly work plan for as long as I can remember, and now it is back on that monthly work plan. They don't add it every single month. They just tell you, like I said, now it states that it's partially completed, but typically they'll tell you the month it started or if it's completed. This is exactly what it will look like when you pull it up. So you can see in the center, that's the severe malnutrition. And then there's a hyperlink that you can click on, and that's what got to the screen that I just showed you. You can see over here that it says it's partially completed, and the expected issue date is 2019. But again, if I was a betting woman, I would say that this is going to keep going on, as it appears severe malnutrition is always a hot topic for the OIG. And when, like I stated before, you've heard all this information, you want to start this at your facility, but you're just unsure how. We recommend starting with the OIG work plan, as that is the hot topics that the government is looking at, and it is the most up-to-date and active list. There are several other places that you can look, and Rachel is going to list a few of those out for you now.
Thanks, Susan. Okay, so not to overwhelm everybody with all these different areas that you can look for focuses from the government, but here are some other other ways to guide you on choosing where you might want to focus some of your audits from your internal audit plan. So CMS Guidelines and Transmittals. Make sure that you have notifications, you've signed up for the notifications, so you do get information from CMS, but also from your MAC, because that's going to be specific to your region and specific to your contractor. And you can sign up for their alerts and their newsletters, and those are extremely helpful to see what areas are they looking at, what are the new billing guidances that they're putting out, and what might you need to communicate to your business office and to your coders so that you can make sure that those bills go out correctly. Definitely review your denial information. And we could have a completely separate presentation just on denials analysis, but this is an area that really helps point you in directions that need some extra attention in your organization. For example, if you're seeing denials with a certain drug, for example, well, maybe that's pointing to a prior auth issue. Maybe you're seeing denials based on medical necessity with a specific test that's being performed and ordered, and that might prompt you to take a look at, well, who is ordering this test? Is there some education that can be provided to this particular provider? Is there a documentation issue? Should we be coding this differently? There's a lot of different things that you might find out just from that one denial that you're seeing. And then we already talked about new service lines, or if you're experiencing growth in an area, maybe you've expanded a service line and so now your volumes are increasing. Definitely conduct reviews when those new service lines get up and running, and when you've got that volume there that you can start pulling some records and reviewing that documentation and those billings. Other regulatory audits, of course, is the RAC and UPIC. I did include a link here for the RAC topics, and I have a screenshot here. So when you click on this particular link, it actually brings up this page on the website, and you can see then what the RAC is focusing on. And bariatric surgery has been around for a while. We've got PET scans on here, medical necessity as it pertains to in the SNF setting. So if that's an area that you need to look at, that's on this list. And then E&M coding during when the patient's an inpatient, and those codes are specific to home visits. So if you're performing any of those types of services, you can focus in on those. And then we've got medical necessity as it pertains to blood glucose monitoring. So these lists are going to be, like I said, based on that, those RAC reviews, and then also there's a date there on the far right column, which tells you when those were put on the list. Okay, so now you've conducted the audit, and we've pulled together all of this information, and we know that we've got risks in certain areas, but we do need to formalize all of that information that we've brought together. So the report of findings is important for us to then turn over and share with staff. And what we typically do initially is make sure that the frontline staff, so that would be your coders and your billers, that they have an opportunity to review that detail. And they're able to go claim by claim or medical record by medical record and review the findings from the audit. So if you performed a review, it's usually maybe the detail is in like a spreadsheet of some sort. You give it to the coders and the billers, they review the claims, and they get an opportunity to really dig deep into those and offer any explanations for why it was billed the way that it was billed, or if they feel that the documentation does support something that was billed, they can have that conversation. And it's usually a really good back and forth between the auditors and those that are actually performing the work, for them to share information with one another. I know that for me personally, I always learn something new when we're having those conversations, and every organization has different structures and different systems in place, so those conversations are very beneficial. And so once we have a chance to then review the explanations or the rebuttals from the coding staff or the billing team, then at that point we can start issuing more of the formal report and giving that to internal audit or the compliance officer for their review. So then next steps, we've gotten to the point now where we've performed our assessment, we've got our audit plan in place, we've performed the audits, and now we're getting into the area where we're sharing information and we're submitting those reports. And now what do we do now that we have this report, and how do we pull all this together? So we're going to be examining the findings. We've put that in a report. We're sharing that with the internal audit team, and they're going to be reviewing that document, probably asking some questions of the auditors, trying to understand how we arrived at our conclusions. What are the trends that we've identified? Where do we think that we need to go next? What is the most urgent matter that requires our attention? Where do we need to focus our efforts initially? And we start developing an action plan and putting together recommendations for the department or area that we just audited. And an essential piece of the action plan too is developing a method for following up on the recommendations. It's one thing to issue an action plan and say, this is what you need to do. But we also need to make sure that there's some accountability following that, and that the corrective action steps have actually been taken. And sometimes that requires a little bit of guidance from the audit team, working with that department to develop what action makes the most sense and is the most realistic for the department to perform. And we want to make sure that the steps that we take actually fix the issue going forward. And it's not just something that we do, but it doesn't really have any impact. So in talking about corrective action plans, so some considerations with this is, how are you going to track that corrective action plan? What is going to be the acceptable interview for follow-up? Do you want to follow up within 60 days, or is it 90 days? Is it less than that? And depending on the issue, maybe there could be a little bit more time associated with that, depending on how big the issue is, or maybe there's a system that needs to be implemented and that might take a little bit of extra time. And then how do you maintain independence during that presentation of the audit results? One thing is that, sometimes depending on the size of our organization, we might have an auditor that actually audits the department, and they're a part of that department. We would make sure that they're not reviewing any of their own work, but they might be reviewing work of their peers. So when we present the audit findings, it's best to maybe remove that person from actually presenting, and they turn that over to someone, one of the leaders in the internal audit team, to present the findings, so that there isn't that, that awkwardness of presenting findings to your peers. In an external audit situation, it's really not an issue because your audit team and your auditors are not from within the organization, but it's just something to keep in mind when you are using auditors from within the organization. So this is just an example of what a corrective action plan might look like. We would identify the issue and indicate the findings on the plan, the auditors would. And then it would be up to the department to identify the actions to be taken. Here is what we plan to do in order to address the issue and the finding that was found during the audit. And then they also identify a responsible party. And we encourage that the actual person's names are listed under responsible party, so that we know who is that person that we need to contact when we're getting ready to follow up. And that timeline is the key portion of this too, because that's going to indicate when do we need to follow up and make sure that the action that was said to be taken actually does occur. And then we have the responsible party that we can identify and we can go to and ask, oh, did this get completed last March? And if not, why didn't it? And what support or assistance might that department need in order to complete that action? Okay, Susan, I think I'll turn it over to you.
Thanks, Rachel. So in conclusion, we really want to stress the importance of all departments working together within your organization. As someone who has been reviewed and has also reviewed others, there is no worse feeling than having your work reviewed and not having a chance to say, hey, this is why I coded it like that. There may have been a transmittal that came out that maybe a different department didn't see. There may be something that's super payer specific, and that's why you coded it like that. So it is just really important that you're able to have your voice heard as well. We've seen throughout our travels that when departments feel like they are being included, whether it's coders or even clinicians, they're just more likely to have a positive response to that review. We know for a fact that providers like to be heard as well too. Sometimes they feel like they're just told, do X, Y, Z, and they have to do X, Y, Z, and they're not always sure why they're doing X, Y, Z. So we just like to see that positive response. We also like to see the facility utilizing a team approach and a shared responsibility, and that can overall help you improve your compliance. And with that, I'll turn it over to Rachel for any closing thoughts. And thank you all for listening today.
Thanks, Susan. I was just going to add too on that we often see too that just having maybe a kickoff type meeting before you start the audit can sometimes just help alleviate any anxiety or nervousness, or even just that feeling of, oh, I must be doing something wrong, that's why they're auditing me. But if you're able to set the stage from the beginning and say, well, this is something that's on the OIG work plan, or this is something that resulted from the risk assessment that we just performed, and we just want to make sure that we have a good understanding of your processes and your procedures that you have in place, that might help alleviate some of that anxiety or that feeling like you're doing something wrong. And including both clinicians, if let's say you're looking at the cardiology department, maybe some of the clinicians from that department can be involved, as well as the coders and the billers or individuals from revenue integrity that are associated with that area. They can all be together for that kickoff meeting and understand the purpose of the audit, what steps we're going to be taking during the course of the audit, the questions that we might ask, and the people that we might meet with. And I think that helps make for a smoother audit from the get-go. And then constantly communicating throughout. If you're finding something over and over and over again with each record that you're looking at, sometimes it's nice to stop and just take a minute, ask a couple questions, and it might clarify what you're finding so that you are able to have a better understanding of it before you're putting it into a report or issuing the findings at the end, and then you find out about it at the very end and realize it didn't need to actually be in that way. So I just want to reiterate what Susan said in stressing teamwork and taking that team approach and really alleviating any feelings from the group that they're under attack or they're being singled out, and they understand that this is just for the betterment of the organization as a whole, and we're all in this together and we're all just trying to do the right thing. So with that actually concludes our presentation for today. Susan, did you have anything to add on any of the, maybe some examples of different types of audits that we've been doing lately? I can probably think of some as well that have been interesting.
Yeah, absolutely. I just did one that was definitely out of the box for me. I've been in the health information arena for, like I said, 25 years, but my main focus has been coding. Well, this particular review ended up being transcription, which was kind of neat because way back in the day when I was first starting out, when there wasn't enough coding hours, I would substitute in as a transcriptionist at this large PPS facility in North Dakota. So it kind of brought me back to my roots. But what ended up happening is a facility had one very, very long-term transcriptionist, someone who had been typing a very long time. And then they had a couple newer transcriptionists, and they were noticing that the newer transcriptionists maybe weren't quite catching on at the same rate. So we were asked to do a review. So I got to listen to the actual dictation and follow along with what the transcriptionist typed to see if there were any errors or anything we could do to help improve their transcription. What we ended up determining was that with a little education and maybe a little one-on-one time with some of the physicians so they could get used to their certain way that they spoke or any abbreviations they used, that we felt that the transcriptionists were going to come up to speed, up to par with the more veteran transcriptionists. So that one was kind of fun. And anytime we get to do any sort of reviews on anesthesia or interventional radiology or spinal surgeries, those are always really fun ones. Those are high dollar accounts with lots of opportunities to find extra charges or to find some lost revenue. Those are the ones that I can think of recently, Rachel. And by the way, does anybody out there have any questions? I'm not sure if you know that you can type them into this Q&A little box down in your corner, and we can see them live.
And I'll also add too, what kind of an interesting audit that was different outside of the norm, it fall probably more under the billing category, was a Medicare secondary payer audit where CMS had been into the organization and had found that they were not completing their MSPs. And so they were put on a corrective action plan, and they had a period of time where they could get their processes in order, and they knew that CMS was going to be coming back. So in the meantime, they trained all of their staff, they put in some policies and procedures, and then we were asked to come in and perform a review before CMS came back to perform their review. And I will say that everything looked great. We interviewed all of the employees, and we read through the policies and procedures, and every employee knew those policies and procedures verbatim by heart. They knew them forwards and backwards, and we honestly thought they've got it all figured out. So it wasn't, but the next day when we were actually doing some job shadowing, that we found out that what was being said and what was being done were two very different things. And so it was a really, it was a great audit from the perspective that we found what we needed to find, and we were able to give the organization the information that they needed prior to CMS coming back and performing their review. So, but it just reiterated for us that sometimes we may know everything that we're supposed to do, but then actually performing it in the real world is a completely different animal, and we need to match those two things up.
Yes, I sure did. Thank you. That is absolutely correct. A viewer stated that a facilities PEP report also provides areas for internal audit. And yes, I could not agree more. There are just so many a plethora of things out there that we can use. We just pared it down to only the few that we put on these slides, but absolutely, she's correct. So your PEP report can also provide areas for your internal audit on the hospital side.
And I would even say too, I know we talked about denials a little bit, but also if you're just seeing some interesting spikes or utilization of various codes within your organization, and that seems out of the ordinary, like, oh, all of a sudden I'm seeing this code being utilized all the time from this department, and we haven't ever really seen that before. Well, when you start doing some digging, you might find out that, oh, somebody went to a conference or a seminar and learned about this code and thought it was applicable to what they were doing and started charging it. And maybe they didn't necessarily know or understand exactly what the code should be used for. So it's an opportunity for education. But if you're not monitoring some of those trends, then you might miss something like that too. So it's just a good reminder to look at our data. And if you don't have good reports, or you're not receiving reports, then it's important to make sure that you request those and have a means of gathering that information.
Absolutely. And if anything comes to your mind later on today or next week, our email addresses are here. Please feel free to email us or give us a call.
Thank you, ladies, so much. We appreciate it. If more questions do come in, I can get those recorded for us. But I think we are good to go. So everyone saw our upcoming June schedule listed on the screen there. If you do want to join us for any more of our webinars, you're more than welcome to join. Just visit our website. And this webcast was recorded, and we will get it sent out to the participants. Give us about 2 weeks to get everything edited and sent out. So thank you, Rachel and Susan, and everyone have a great day.
Thank you.
Thank you.